Welcome to our discussion here on cervical screening. I am not going to talk about cervical cancer here. Cervical cancer is a very important topic and you want to know about it for the test and definitely for seeing patients. If you're seeing female patient population, you need to know about cervical screening and cervical cancer, but we're going to limit ourselves here to cervical screening and to some of the abnormalities that you can see, but not including cancer. But keep in mind that some of these abnormalities, they can lead into invasive cervical cancer. And so you really can't separate the two of them apart completely. But I want to focus here on the pre-malignant lesions as well as give sort of an overview of how we go about doing cervical screening, because it is a part of the well woman visit for any woman of wide variety of ages. Okay? A 22-year-old female graduate student presents to the University Health Center for a physical exam. She has no complaints at this time and simply wants to establish care with a physician. She has no significant past medical history, no major health issues. She's on no medications. She has had sexual intercourse one time in her life, which was with a long-term boyfriend. It was last year, and she says they use protection. She has never been pregnant. Apart from coming in for routine vaccinations, she has not been seen by a physician since her high school physical 7 years ago. Which outpatient gynecologic procedure is most appropriate at this time? So you can see she's talking to her friendly provider, who could be an NP, a PA, an MD, DO, what have you. And she is in no apparent distress. She is simply there to establish a relationship with a physician, so if something ever goes wrong, like she gets herpes or maybe just a cold, that she has somebody she can go to. This is not uncommon. You will see healthy patients coming in just for routine checks and physicals. However, that doesn't mean that these visits can't be complicated, because there are a wide variety of screening exams that we do for patients that are not otherwise ill, but we want to do these screening exams to prevent them from becoming ill. And some of the screening exams that we do, they're established, and there are recommendations of how often we do them, when we may need to do them more often, etc. And the one we're looking at here, as you can probably imagine based on the name of this lecture, is the Pap smear. Alright, so she is going to need a Pap smear, and as we're going to see, all women need to get Pap smears starting at age 21 or 3 years after her first sexual intercourse. Okay, so girls are having sexual intercourse at younger and younger ages. It's not unusual for a girl to have her first sexual intercourse at 15. In that case, 3 years after 15, she's going to need her first Pap smear at 18, not 21. Now, she's 22, so she should have had her first Pap smear at 21. She had intercourse last year, presumably when she was 21, but you don't wait 3 years after that. It's 3 years after your first intercourse or 21, whichever is younger. Okay, so she is on track for her very first Pap smear. You'll want to be gentle with her, because I'm not a woman, but as far as I know, it's not the most comfortable procedure. It is an outpatient procedure, can be done in the clinic, very cheap, very easy to do. She can probably have it done right then and there. So we're going to look at the importance of Pap smears, how we time them, going about sort of the regular patient that doesn't have abnormal Pap smears. What does the schedule of their Pap smears look like throughout their lives? When can you scale it back? When do you have to do them more often? Then we'll also talk about some of the results you can get from Pap smears. Most Pap smears will come back normal. About 1 in 15, 1 in 20 will come back with an abnormal cytology, and in that case, we need to do more things. We need to investigate further. And so we'll talk about what each of these cytologies are and what they implicate. Then what do we do after the PAP? Once we get the cytology back, what do we do? And then finally, we'll talk about the cervical dysplastic histopathology. You'll probably see where we're going here. And this gets graded a little bit differently because this is a histologic specimen. And this is really going to be what tells you how you're going to go about managing the patient. All right, so sort of the way this works, you get a Pap smear comes back normal, good to go until your next Pap smear. Comes back abnormal, then you need to look at your cytology, and then based on what the cytology is, you may need to get a biopsy. The biopsy gets sent off to a histologist. The histologist will make the decision as to what the invasion level is, and that invasion level is going to dictate how we definitively treat the patient. All right, so let's go about this step by step. Our anatomy of the cervix is pretty simple. You have the vagina out here going inwards into the corpus of the uterus. You have this canal called the cervix. And the cervix is approximately 4 centimeters in length, roughly the size of your finger, or my finger at least. It's about maybe a little more than 4 centimeters, but maybe take your pinky finger. That's about 4 centimeters maybe, but you get the idea. It's not a super long canal. It can be a little shorter in some women, a little longer in others, but for the most part it's inconsequential unless it's really short, like 2.5 centimeters or less. In diameter, it's only about 8 millimeters to 1 centimeter, so it's not a very wide canal. But as you know, the cervix dilates quite significantly during childbirth. It gets up to 10 centimeters in diameter. So you're talking about a 10 to 12-fold increase in the diameter of the cervix during childbirth. Okay, but what you want to be aware of as far as Pap smears go, and looking into some of the precancerous lesions of the cervix, you want to be aware of what we have out here, the ectocervix on the outside, and the endocervix, this tissue on the inside of the cervical canal. Okay, who is this man? This man's name is Georgios Nicolaou Papanicolou, and he was a Greek-American cytopathologist, and he is the father of the Pap smear. Papanicolou, we take the first 3 letters of his name, Pap smear. Basically, he was seen as sort of a, I wouldn't say that he was necessarily ostracized for his beliefs, but he was certainly outside of orthodox belief in that he felt that cellular debris from the female reproductive tract can give clues to various parts of where a woman is at in her menstrual cycle, and possibly predictive factors into whether or not she has a cancer or cancer developing. And the way he came to this conclusion, or to this hypothesis, is actually quite interesting. So he had a wife, and when he was in his formative years as an aspiring researcher, Mrs. Papanicolou got up onto the couch every day, so that he could get scrapings from her cervix. And then he took those cells and looked at them and looked at the changes. And he saw at first, indeed, that there are changes in these cells that coincide with the menstrual cycle. Later, he would come to realize that there are also changes in the cells that are associated with the development of certain cancers. He was looking, I believe, at cervical cancer, but also on uterine cancer as well. So in 1928, when he was 45 years old, he presented this method to a medical conference in Michigan, and they basically laughed him out of the room, saying this is crazy. Well, about 12 years later, he teamed up with a gynecologist by the name of Herbert Trout, and together they published a paper on the diagnostic value of cells in predicting and detecting cancer. And after this method was refined over the years, we have come to a rudimentary idea of what we now know as the Pap smear. And over the last 60, 70 years, this technique has been perfected, and that is what we now have, is the Pap smear. Particularly in the 1970s, we began using the Pap smear much more often, using it on more and more patients, established guidelines for when you do Pap smears, and we do them regularly now. And as you can see here, this is looking at cervical cancer, and we're going to be talking about neoplastic changes, not necessarily cancer in this lecture, but this is looking at cervical cancer. And in the 1970s, the number of cases in the U.S., this is going by year, but it was roughly 20,000 cases per year. By the 1990s, we're down to about 13,000 cases per year. So pretty significant. We're talking about a 30 to 40% reduction in the incidence of cervical cancer, and this is attributed to the Pap smear. Why is there this increase in incidence? I'm not sure. Maybe it's because more people are having sex more often. That is a risk factor for neoplasia of the cervix. As we're going to see, this is an HPV-mediated process. But this general decline also coincided with a decline in mortality. 10,000, roughly, deaths per year from cervical cancer. We're now down to around 5,000 deaths. So we've cut that in half. And this is true of the industrialized world. Now, if you go out to East Africa, where there's not very good healthcare in general, much less preventative healthcare, which is really a luxury we have in industrialized countries, cervical cancer is actually the #2 gynecologic killer of women as far as cancers go. So they have a long ways to go. And as you can imagine, preventative treatment would prevent a lot of undue burdens on their systems. It costs about $30 to $40 to do a Pap smear and to get your readings from that, and all of the things you do along the way are much cheaper than treating for cancer. Cancer, chemotherapy, radiation is much more expensive than any of these things we do along the way. So if we're looking at saving money by helping these countries out, it's really primary prevention that's going to have the greatest effect. So this is the Papanicolou smear. These are the tools that you need. Not a whole lot. This is just a very rudimentary kit. But you have 2 different brushes that you use. We'll talk about that. You have your speculum. Nice handy speculum is always good to get a nice view of the cervix. But some speculums these days have, like, you plug them in and they have like a fiber optic light. Those are really nice. Otherwise, you have to sort of use ambient light or get a lamp behind you or a flashlight. But this is your basic speculum. You have these 2 brushes. Note one has these bristles. This you're going to insert into the endocervix. And then this one is, I believe they call this a spatula or a brush. And this is where you get your scrapings from the ectocervix. Okay, so this is one of the cornerstones of the gynecologic visit. You should always assess the record of any woman presenting at her annual physical to ensure that she is up to date on her Pap smears. Not every woman at every visit is going to need a Pap smear. Okay, but if you see that the year is 2016 and her last Pap smear was 4 years ago and she is now 28 years old and she should be getting Pap smears every year, then she's going to need a Pap smear today. All right? The exam is very simple in practice, but you should understand why you are doing what you're doing. Okay, so why are you getting endocervical cells and ectocervical cells? Because you can develop cervical cancer in either of those areas, and you want to know where it's at. So this is a cervix here, visualized with a, I don't know if this is colposcopy or speculum examination, but it's zoomed in pretty good, so you might be able to say it's colposcopy. Either way, you have this area that's of the utmost importance when you're talking about doing a Pap smear, and that is called the transition zone. And you note the transition zone where you're moving from squamous to columnar epithelium. This is this transition zone is the area that cervical cancers are most likely to develop. And the cells in this transition zone, they go through a metaplasia that's responsive to estrogen. And so some of the times that you're most likely to develop a CIN, cervical intraepithelial neoplasia, which is precancerous or can be precancerous, those times are going to be around menarche and after pregnancy. That doesn't mean that those people are necessarily at higher risk. It just means that these cells, they will change around that period. These cells are responsive to estrogen. So this gives us a few pearls. We know that CIN, is most commonly diagnosed in women in their 20s. We also know that carcinoma in situ is most commonly diagnosed in women aged 25 to 35. Why? Because it takes that CIN some time to develop into carcinoma in situ. Incidentally, the average age for invasive cervical cancer is not until 40s and 50s. Okay, so you're going to take your little brush and go around here along this transition zone. Make sure you go around the whole thing, and then take your little fiber thing and go into the endocervix. And you want to get both of those. So to Pap or not to Pap? How do we know if a woman who's coming in needs to be Papped or doesn't need to be Papped this time? So I set forth some guidelines here. You may run into some conflicting recommendations. I got this from a gynecology textbook, Williams Gynecology, I believe, and adapted it here. So we're looking at just Paps. Now there is something called a reflex HPV DNA test that can be done. And basically what they do is they take some of the fluid that you get from your Pap smear and they test it for HPV DNA, and that gives you a little bit more accuracy, prognostic value as to whether this woman is at risk for developing CIN or not. However, I'm just going to look at this as Paps only, and if you do have HPV DNA, reflex HPV DNA at your disposal at your facility, then you may be able to be a little less stringent on getting Paps as often. You may be able to discontinue them earlier, but we're just looking at Paps here, okay? So the first Pap, as I mentioned, should take place at age 21 or 3 years after the girl's first intercourse, whichever is younger. So I would imagine, theoretically, if a girl is 10 years old and she was sexually molested, and it was penile vaginal intercourse, then she's going to need to get Pap smears quite early on in life. Or, like I said, girls are having sex earlier and earlier on, 13, 14, 15 years old these days. So you may be doing Pap smears on very young girls, 16, 17, 18 years old. But 21 is the max. Okay, so every woman, even if she is a celibate nun, she needs to get a Pap smear at age 21. Okay, that's the recommendation. Patients can always refuse it once they're at a certain age, but that's the recommendation. No matter what, Pap smear at 21 or 3 years after the girl's first intercourse, whichever is younger. At that point, then subsequent Paps should be done annually until at least age 30. So 21, 22, 23, 24, all the way up to 30. So she hits 30, then what do? Then we ask ourselves a question. Has she had 3 consecutive normal Paps? If the answer is yes, then she does not need to have her next Pap smear until age 33. So you get her a Pap smear at 30, she had a normal one at 28, normal one at 29, the one you did today at 30 came back normal. She doesn't need to come back for a Pap next year. She can come back in 3 years. On the other hand, if she has had an abnormal Pap on this exam, then obviously that's going to change your management, and we'll see that in a little bit. Or if she has not had 3 consecutive normal Paps at age 30, then she needs to continue getting them every year. So if she had a normal Pap at 28, she had ascus, abnormal, at 29, and then a normal Pap at 30, she's still going to need to come in again at 31. Now let's say she's 30, she's had 3 consecutive normal Paps, she then comes in again at 33, that comes back normal, so then she comes in again at 36, and that comes in with ascus. What do we do then? She's going to need to get Paps every year from then on out until she's again had 3 consecutive normal Paps. So she'll come in again at 34 or 36. She had ascus, so she'll come in at 37. Let's say that was normal. 38, that was normal. 39, that was normal. Okay, now you don't need to start for another 3 years. So it kind of resets if you ever get an abnormal Pap. So that's what we do after age 30. But between the first Pap and age, I guess, 29, 30, they need to be done annually no matter what. Okay, now the woman's older. She's 65. If she has had 3 consecutive normal Paps, she may discontinue Paps indefinitely, provided that she does not meet certain criteria. What are these criteria? These are women with significant risk factors for cervical cancer. They should not be encouraged to discontinue Paps. So one would be if they were exposed to DES in utero. DES was used from the 1930s to 1970s for mothers who had had miscarriages. It was supposed to prevent or reduce the risk of miscarriages. It didn't do that, and all it wound up doing was causing a whole host of problems in their female offspring. I'm not sure if it caused problems in the male offspring, but it caused a bunch of problems in the female offspring. Structural problems, but then also this increased risk of an adenocarcinoma called clear cell carcinoma, which we can look for. Not as good for the adenocarcinomas as it is for the squamous cell carcinomas, but we want to continue doing Paps because these women are still at risk for adenocarcinoma. HIV or immunocompromised, why? This is an HPV-mediated cancer. HPV causes this cancer. And so if you're immunocompromised, you have more HPV sitting around, can cause more damage to cells, and that can lead to cancer as well. Chronic steroid use, I think that just kind of comes around with the immunocompromised state. You're suppressing your immune system. Okay, so if these women are 65 and they have none of these risk factors, then if she's had 3 consecutive normal Paps, you can stop. Now, another set of the population are the women who have had hysterectomy. If you have a hysterectomy that removed the cervix, so you've done the hysterectomy and you've taken out the uterus and everything all the way down to the external os, and you've removed all that, then provided that that hysterectomy was not done for any kind of cancer, she can discontinue Paps indefinitely as long as she has not had an abnormal Pap ever in the last 20 years. Okay, so for the test, for board purposes, unless you're talking about OBGYN boards, you probably want to know all this, but if you're talking about just general practice boards, USMLE, etc., you want to know at least these first 3 rules. So start at age 21, or 3 years after the girl's first intercourse, whichever is younger. From 21 to 30, you're getting them every year. And then starting at 30, you can do it every 3 years, provided that she's had 3 consecutive normal Paps. So what can we get back from Paps? Like I said, most of them are going to come back normal, unremarkable. However, in a minority of cases, I believe it is, what was the number? I think it was like 5 to 7% of routine Paps that are done in the US will show an abnormality. And this is read by a cytopathologist. You do not need to know what these cells look like, what the morphology of these cells are, just like you don't need to know histology for licensing tests. Again, if you're a pathologist going over this lecture, you need to know. But for the rest of us, you don't need to know what these cells look like, but you do need to know the descriptors of these cells, because that is going to tell you what you need to do further for these patients, because all of these patients have abnormal Paps, and so they're all going to require some kind of follow-up. So some of the descriptors of abnormal cytologies. The first one is ASCUS, A-S-C-U-S, which stands for atypical squamous cells of undetermined significance. Basically, the cytopathologist sees cells that are not normal, but she doesn't really know what they mean. So she just puts undetermined significance, but she wants you to know that there are atypical squamous cells. Then there's the low-grade squamous intraepithelial lesion. In this case, she sees something abnormal. She knows it is consistent with CIN, cervical intraepithelial neoplasia, which is a histologic diagnosis we'll go into in a little bit. She knows it's consistent with some kind of neoplastic process taking place in the cervix. Then there's the ASK-H. ASK-H stands for atypical squamous cells, and you can't exclude high-grade SIL, squamous, or high-grade squamous intraepithelial lesion. So in this case, again, you don't know what the pathologist doesn't know what they're seeing necessarily, but it might look kind of something like high-grade SIL, but again, doesn't really know, can't nail it down. So they write it down as atypical squamous cells, can't exclude HSIL. This is, as you can imagine, much more problematic than ASCUS, because in this case, the pathologist is telling us that there is a serious possibility that this is HSIL, which leads us to our next one, HSIL, that's high-grade squamous intraepithelial lesion. This is consistent with some of the more advanced histologies that are guiding you towards further and further towards a carcinoma in situ or invasive cervical cancer. So we take this very, very, very seriously when this comes in. And then the last one you can see, which kind of is an outlier here, is atypical glandular cells. Here you're getting a different type of cell, but they're atypical. They're not just regular glandular cells, they're atypical glandular cells. And what this can point us to is an adenocarcinoma, which makes up the minority of cervical cancer cases. 4 in 5 cervical cancer cases will be squamous cell in origin, but 1 in 5 will be an adenocarcinoma. And some of these can derive from the endometrium, and so we want to be aware that if you have these atypical glandular cells, you may need to also be looking elsewhere, and we'll talk about that. So with the exception of ASCUS, the first one we talked about, all abnormal Paps, L-cell, ASK-H, H-cell, and AGC are all going to proceed to a colposcopy and biopsy. Colposcopy is where we take that sort of little microscope looking thing along with our speculum, and we get a really, really good look, close-up look at the cervix and the vagina area. So women with ASCUS, so they don't necessarily need colposcopy and biopsy. What we can do for women with ASCUS, because it's up in the air here, it looks abnormal, but we're not exactly sure if it's significant. What we can do for them is get an HPV DNA test. That test is done, and it will tell us whether or not she's positive for HPV DNA, and if so, is it one of the high-risk HPVs. Remember that the low risks, 6 and 11, those cause warts. They don't cause cancer. HPV 16, HPV 18, the 30s, those are more problematic. They can cause cancer. So if it comes back positive for the high-risk HPVs, then you will get a colposcopy and biopsy. If it doesn't, then you can just repeat the Pap and get an HPV DNA next year. Not 3 years from now, next year. Patients with atypical glandular cells, they're also going to get a colposcopy and biopsy, but they may also need endometrial sampling, and that's going to depend on their age and history. So if a woman is older than 35, she should probably get an endometrial biopsy. Or if she has risk factors for endometrial cancer, so she has abnormal bleeding, she has chronic anovulation, she has very abnormal cytology on the atypical glandular cells, and pathologists might tell you that, then in that case you may want to go forward with endometrial sampling too. So this would be your next step for most of these cases, colposcopy and biopsy. You stick your speculum up here as you normally do, and then you use this colposcope to give you a very, very nice look at the contours of the cervix and the ectocervix in particular. What do we look for when we're doing colposcopy? We're looking for an area that we can biopsy. And when you biopsy, you're just taking a small amount of tissue. And you want to make sure that you're getting the problem area. And if you don't know what the problem area is, if you're looking for possible cervical cancer or a precancerous lesion, then you're not going to know where to go and take a biopsy. Woman certainly isn't going to want you taking 10 punch biopsies out of her vagina and cervix. So you want to make sure that you're taking areas that look suspicious. And so here are 4 things that you want to look out for. One of the things that you can do, and you will do when you do a colposcopy, is you're going to stain the transition zone, the region around it, with acetic acid. And what that will do is it will turn some areas that may be dysplastic, it will turn them white. That would be a good area to get a biopsy. Okay, so as you can see here, we used acetic acid, and we have some white tissue here, and it's turned white from the acetic acid. The rest of the tissue looks fine, but this is white, so you can get a biopsy here. Another thing you can do is look for areas that are mosaic-like in appearance. So look at this cervix, otherwise normal. Look at the tissue around it, looks pretty normal. Okay, especially if you go back here, looks pretty normal. Okay, very confluent. Now, on the other hand, here you have this mosaic-like sort of cobblestoning appearance. And this is another problem area that you would want to biopsy an area here. Okay, so get a punch biopsy in one of these areas. So this is just zooming in on that picture so you can see sort of the cobblestoning mosaic-like appearance. What else? Areas that display punctated vessels. This is consistent with sort of a leukoplakia kind of like process, which is something that squamous cell cancers in general can manifest, and they get these like punctated vessels on these plaques. And so these are suspicious for like a neoplasia. So these punctate vessels. And then finally, areas with abnormal vessel geography. What does a normal vessel geography look like in the cervix? So here is a cervix. You have vessels that look like they're almost kind of coming out of the cervical canal. But what they should do is arborize. What does that mean? It means make a tree-like shape. And you can see that these vessels kind of come out of the cervical canal. I'm not sure if that's what they're really doing, but these vessels come out and they split up and they get narrower because you're forming these little tributaries. If you have something that doesn't look like a tree, then it's probably abnormal. So here you can see you've got these hairpin loops. You don't have that here. Okay, these vessels, they go out to the margins, they get thinner. Here you have hairpin loops. They're turning around and twisting in all sorts of different ways. Here you have vessels that are coming out. I'm not sure where the cervical canal is here, but you have vessels that are moving in all sorts of different directions. Some of these vessels, as they're getting further away, I think the cervical canal is up here. Can't tell really, but as you can see, they're coming away, they're turning different directions, and they're even getting thicker as they're moving away. So these are abnormal. This is abnormal vessel geography. This is one of the harder ones to pick up on. I would say the easier one to pick up on if you're a novice would be the white areas or maybe these mosaic like areas. But these are traditionally 4 areas where you would want to get a biopsy if you saw it on colposcopy. Okay, so we got the biopsy. We send the biopsy to the histologist, who will then assess it and label it based on the depth of abnormal cellular invasion. So they take the slice, they look for abnormal cells, they know what normal looks like. You should know what normal looks like. You don't need to know it for the test, but you should know what normal looks like. You learned it in your first year of medical school. And then you should know what abnormal looks like, or at least what happens with abnormal is you get abnormal cells, cells that aren't supposed to be there. And the grading of this cervical intraepithelial neoplasia system here is based on the depth of invasion. So we have SIN 1, SIN 2, SIN 3, that's just increasing in severity. Then we have cervical carcinoma in situ, which would be full thickness, and then invasive cervical cancer. In that case, you have invasion of the basement membrane. These designations are based, like I said, on the depth of the abnormal cells and, importantly, whether or not the basement membrane is intact. If the basement membrane has been violated, then you have an invasive cervical cancer, and that's going to change the entire ball game. We're going to have to stage the patient, and then there's going to be probably some pretty significant surgical interventions. So this didn't really turn out the way I wanted it to. It's a little grainy, but this is what a normal cervical epithelium looks like. Note that you have these more basophilic cells down here, and then these sort of clearer, flatter, more squamous cells up here. Now with these changes, these darker cells show up a lot higher up. Okay, so note that these dark cells, they're very limited. They're only around the base. Here they're coming up, and these are abnormal cells. So SIN 1, it's restricted to the deep 1/3 of the epithelium. So these are normal cells here. You should see these halos, kind of like you see up here. But these dark cells, where you don't see a lot of cytoplasm, I would say they come up to probably, highest one is probably right up here. So restricted to the deep 1/3 of the epithelium. Okay. SIN 2 is approximately 2/3 of the epithelium. So again here you look, you've got abnormal cells. This is an abnormal cell. This is an abnormal cell up here. So it is definitely 2/3 of the epithelium here. This is the end, this is the beginning, so 2/3. SIN 3 is more than 2/3 of the epithelium, but not necessarily full thickness. And then CIS is full thickness, carcinoma in situ. Now there's some debate amongst histologists, when does SIN 3 become carcinoma in situ? And there's not really a whole lot of agreement, so you may find different answers. But the general consensus is that carcinoma in situ has to be full thickness. It's really just an advanced SIN 3. What do these all share in common? There's no invasion of the basement membrane. The basement membrane is entirely intact in all of these. If the basement membrane becomes violated, then you're going to have invasive cervical cancer. So then what do? The histologic diagnosis will give you the information you need to decide what therapeutic interventions should be taken, as well as information regarding prognosis and future surveillance, which will be done with Paps and HPV DNA tests. So for SIN 1, we can just repeat the Pap at 6 and 12 months, or we can get an HPV DNA at 12 months. Either approach is fine. Now when you do get one of these, if you get abnormal results, then you need to repeat the colposcopy and get a new biopsy, because it's possible that this has progressed to SIN 2 or SIN 3, and if that is the case, then that's going to necessitate a resection. It could also be that it's still SIN 1, and then you just repeat this again. If you get normal results, you could just return to Pap smears, routine Pap smears, but they need to be done annually. You can't go back to every 3 years. That's just a privilege for people who have had gold stars at all their Pap smears. You're going to have to go back to annual Pap smears because she did have a abnormal cytology. So annual Pap smears. Now, It is possible that if you keep getting these abnormal results and they keep coming back sin 1, if this happens like 2 or 3 times, you can go ahead and do a surgical resection we're going to talk about. So you can do that for sin 1, but typically it's reserved for the women who just keep getting these abnormal results repeatedly. And they repeatedly come back as sin 1. Now, on the other hand, sin 2, sin 3, and carcinoma in situ, they all necessitate surgical resection. So there are various methods that can be done, really based on the, importantly, based on whether or not there's endocervical involvement, but then also you want to take the woman into consideration as well. In adolescence, we want to be a little bit more careful in how much tissue we take out, because one of the downsides to these procedures is that it shortens the cervix, it can cause scarring of the cervix, and that can lead to obstetrical complications. And so we certainly don't want to make it harder for her to bear children. So we're usually a little bit more careful in adolescence. But the gold standard technique that we use for removing these lesions is the loop electrical excision procedure. And so that would be the one you'd probably be asked on a test. But other things include a modified version of the LEEP, which is known as a 2-stage LEEP. In that case, you're removing also part of the endocervix if that's involved. There's also cold knife conization. That's another approach. I don't think it's any more superior or inferior to the LEEP. And then there's laser conization, and that can be done if you really want to preserve tissue, if that's your major goal, in addition to getting rid of the abnormal tissue. So that would be something you might go after in like an adolescent patient or a young woman who is planning on having children. This is what the LEEP procedure is. I'm not a gynecologist. I've never done one of these in my life. I've seen probably 5 or 6 of them being done, but basically what they're doing is they're taking this wire, they're burning tissue, they're kind of cutting off a little shape here, and that shape should include all of the abnormal tissue. And so to some degree this will heal, but you're removing the abnormal tissue, but you are shortening the cervix to a certain degree. And so you need to remember that one of the complications of this is cervical insufficiency. As you shorten the cervix, that's going to be linearly related to those kinds of obstetrical complications related to cervical insufficiency, which can be like preterm labor and stuff like that. Okay, I wanted to finish with this, the natural history of cervical intraepithelial neoplasia lesions. So this is just looking at sin 1, sin 2, and sin 3, and this kind of gives you an idea why we can kind of sit back and relax on sin 1 and just repeat Pap smear, repeat HPV DNA in 6 months to a year. Whereas with sin 2 and sin 3, we're going right in for these relatively painful LEEP procedures. So we take each of these and we look at, and I got this out of Blueprints Gynecology, had a nice little table, but we look at these sin 1, sin 2, sin 3, and then we look at how many of these persist and stay. I don't know how long, if they checked a year later or 2 years later, but how many persist, how many spontaneously regress, that can happen, and then how many progress to sin 3. And we're worried about sin 3 because with sin 3 there is a serious risk of progress to invasive cancer. About 1 in 5 to 1 in 10 of these women with sin 3 left untreated will progress to invasive cervical cancer. So with sin 1, 90% will either persist or spontaneously regress. So when you see her a year later, 9 out of 10 chance it's going to be the same lesion or it'll be gone completely. So the benefit to doing, now on the other hand, if you were to go in and treat her like sin 2, sin 3 and do a LEEP, then you're going to have all the drawbacks from that. You can cause obstetrical complications later on for her. And it was really only a 10% chance that it would have ever progressed to the point where you would have actually needed to have done that. Okay, 90% chance that this is going to stay the same, and really, in more cases than not, it's just going to regress completely. So that's why we watch SIN 1. With SIN 2, we get rid of it because 1 in 5 of these women will progress to SIN 3. And then once you're at SIN 3, you have a 12 to 22% chance of progressing to invasive cancer. And really, the odds of spontaneous regression are less than, it happens less often than it does. So we make the judgment call that we're going to just remove this. And then also, 1 in 20 of these women with SIN 2 are going to progress to invasive cancer if you don't do anything about it. And that's not a negligible amount. 1 in 20 doesn't sound like a lot, but if you're that 1 in 20, it's a big deal. And then SIN 3, obviously, you're getting pretty high up there, 12 to 22% chance at progressing to invasive cancer, so we want to get this out pronto. All right, so that is all I have for you here. I'm going to do another lecture very soon on cervical cancer and how we manage that. But this is a good intro to cervical cancer because all cervical cancers start out as a SIN 1, becomes a SIN 2, becomes a SIN 3, becomes a carcinoma in situ, and then left untreated, it will develop into invasive cancer. So we will pick up on cervical cancer at a later date. If you have any questions, go ahead and type me a note below. I will see you next time.